I am Dr. Muhammad Umar Khan, and it's an honor to moderate a session in this prestigious event. I'd like to call upon the stage the chairs Professor Ghasun Nabi Tayyib Saab, Professor Wasimuddin Saab, Professor Saleh Saab. Please, if you can join the chairs. Dr. Shah Yusuf. Thank you. So, Dr. Sobia, a consultant endocrinologist, was expected to give a talk on medical management of obesity, but she is busy in CPSP exams, so apologies from her side. So we'll go to our next talk, which will be delivered by Dr. Hamad Ashraf, who is a UK trained consultant gastroenterologist of Pakistani origin, and with an interest in endobariatrics. He is going to tell us something about endoscopic management of obesity. Dr. Hamad Ashraf, please.
Thank you for the kind introduction, and thank you for inviting me, and congratulations to the management team for putting up a really good show. The timing of this talk could not be better, talking about obesity immediately after enjoying a really nice lunch. I'm also really thankful to the scientific committee to ask me talking about a subject which used to be very close to my heart, but it has traveled a few steps downstairs and it is now a bit lower and is taken the central stage. And I do not look like this by choice. The driving forces which make me up in the middle of night and walk to the kitchen and eat that brownie that I did not earlier on are really strong, and I need some support for that. And it does not give me any pleasure knowing the fact that it's not only me who look like this. I would find another couple of people out of 10 on the street if I'm walking in Pakistan. This is a screenshot from Global Obesity Observatory. This is I would say old data, and new data would show you higher prevalence of obesity and overweight people in Pakistan. And this is a slide I really include in all of my talks, because in people who come from countries similar to our, especially Muslim countries, we are really leading in the diabetes prevalence. And I do not need to tell this audience what obesity can do to us. With the development of diabetes and hypertension and dyslipidemia, and then micro and macrovascular complications, heart attacks and strokes, and effects on the eyes and whatnot, and the migraines and the back pain and the joint pain, and the sleep apnea and the infertility and the mental health disorders. These are a few to name, and this slide might look a little populated, but I'm sure it can be more populated. I hope I have made it clear enough that we need to do something about this. And of course we can do something. We've got a few tools to hands. We can apply the lifestyle modification, which include the diet and exercise and some behavioral changes. We have very nice medicines available, and over the last decade we have developed many more. And last night we had a news of Eli Lilly's oral GLP-1 showing robust initial results. And of course we have our most beloved endoscopy in the game, and well-established surgical treatments for the management of this disease. On a balance of how invasive our approach is and how efficacious and durable our choice of treatment is, of course the lifestyle modification is least invasive but least efficacious as a result. And at the other end of the spectrum, we have the surgery, which is highly effective, but of course comes at a cost. And I would be lying to you if I told you that I haven't felt like these two models trying to lose weight over the last few years. The conventional methods, they do not work. They do not work, especially when the disease has advanced. But still, they remain the backbone of any other additional weight management tool that we apply. The main problem with the conventional methods is the sustainability. You might be able to lose a little bit of weight, but it will come back as soon as you lose the grip. And of course, we have the medicines available, mostly in the form of once a weekly subcutaneous injection, which are the most effective and very much in fashion. And I've talked about the oral GLP-1, which was, let's say, released last night. They are very effective. They do help you lose weight when applied, especially in combination with the lifestyle modification. But the problem is the sustainability. You have to commit to these medicines for indefinite period of time. The sooner you stop injecting or taking the pill, the weight will return and will often overshoot the baseline. And before talking about the endoscopic methods that we could use to help lose weight, let me put a few slides about the surgery. Of course, over the last 4 and 5 decades, we have the surgery very well established, showing absolutely marvelous and durable results, but it is not safe. Unfortunately, the morbidity and mortality has limited the use of surgery in obesity management. In the United States, about 99% of people would not choose surgery even though they qualify for it, both medically as well as from the insurance providers. Another slide to support this argument. And then, as you can imagine, between the lifestyle modification and the pharmacological therapies and the surgery, there is a huge gap, a massive unmet need where we can help. And as a result, the endoscopic, bariatric, and metabolic therapies have emerged as minimally invasive, highly effective, incredibly safe treatment tools. And they not only help you lose weight, but also manage the associated comorbidity. And there is a lot of data to support that. And the endoscopic, bariatric, and metabolic therapies are evolving. We started with intragastric balloons. We have moved on to gastric remodeling procedures, and they are very much, they're coming into play very rapidly. We have used and tried other methods and given up on some, for example, aspiration techniques and using some bypass sleeves, and more procedures are in development. A talk on endobariatrics cannot be complete without talking about the intragastric balloons. They come in all shapes and sizes and all kinds of varieties. They do work. It's a little bit hard for a lot of people to tolerate them, but most do, and a small percentage of people would like you to remove the balloon early on. Most will tolerate for 4, 6, 9, or 12 months, for whichever duration you put the balloon in. You can have gas-filled, you can have a liquid-filled, gel-filled balloons. You can have adjustable balloon that you can increase and decrease the size according to the need after certain period of time. And now you can have a balloon that you can just swallow like a capsule, and that does not need endoscopy to insert, and also not for the removal. It will disrupt itself after a few weeks. As I said, the balloons, they do work. They help you lose weight about 12 to 15%, but the problem again is sustainability. Once the balloon is gone, the weight would come back and again sometimes could overshoot the baseline. Despite this, the market for intragastric balloon continues to rise and is expected to continue to rise for at least the foreseeable future. Now, what is really helpful is the gastric remodeling procedures at the moment. We might have better procedures, we might have better combination treatments, but in the endobariatrics, this is what the current favored, ideal, and most loved method is. And that is reducing the gastric volume by plication. The most commonly used device is shown in this picture, which is the overstitch device that you can mount onto any standard gastroscope. You go inside the stomach, pull the stomach all the way up, and use full thickness stitches in a particular pattern, whichever you like, and pulling the thread back, making an effect like a pursing suture, and thus reducing the stomach volume by about 70 to 80%. I'll see if this picture, if this video can show you how it is done. So the scope that goes in has the device mounted on. You would, through a helix, this is the instrument which is called, you will pull the stomach, cross the thread across, put another one in, and do the same in a U-shaped pattern is the most commonly used pattern. You'll pull the thread out, and that will narrow down the stomach and also would reduce the length of the stomach in the longitudinal dimension. You continue to do that until you can, essentially from prepyloric area to near the fundus. And if I can show you another real life scenario, this is a case that we did about 4 months ago. Prior to the surgery, you will be able to see the big drum of the stomach, the diameter. Have that picture in mind, and now after the surgery, you can see how narrow the stomach has come down, and the length is also reduced by about 10 centimeter. The procedure works not only by reducing the volume of the stomach, but also by delaying the gastric emptying to almost half, and there is a complex interplay of hormones that helps the weight loss. The other beauty of the endoscopic sleeve gastroplasty is the durability. The real world data supports that the weight loss is sustained. Another beauty of this is that you can revise the procedure. A previously done endoscopic sleeve can be done again, and can be done actually multiple times. A previously done surgical sleeve could be revised using the endoscopic technique, and of course the transoral reduction of the outlet after a gastric bypass can also be done. We can use both of these techniques as a primary treatment for obesity, as a salvage option, and also as a bridge to surgery. Same concept, a different tool, which is called primary obesity surgery endoluminal pose 2. It requires 2 different operators. One would show you the endoscopic view, and the other one would use the plication device, more or less similar. Pull the stomach up, pass through a tag and a needle, pull back and cut the thread. Similar results, another device, Endomina, that's a European device. You will have a universal kind of 2 jaws through which, something similar to this, through which you can get the scope through, again pull the stomach up, pass through a needle that will deliver a tag and a thread, and also on the other side pull back and cut the thread. A lot of people think that the endobariatrics and endoscopic sleeve is the future, and the learning curve is really long. So as a result, we should standardize the endoscopic sleeve and use the robotics in this field. So EndoZip is being studied. All you need to do is just put this into the stomach, press a button, and that will do the suturing for you instead of you doing the sutures by hand. An older device which comes between the endoscopic sleeve and the balloons is a transpyloric shuttle. This mimics the gastric outlet obstruction intermittently, delays the gastric emptying, helps you lose weight. Another technique another device, Aspire Assist, similar to the PEG tube that we put in. You eat, you enjoy whatever you like, and about 30% of that after a certain period of time can be aspirated. Real patient's video, weight loss, but some complications obviously are prohibitive to the use of this. Duodenojejunal bypass liner again has been studied. This is about 60 centimeter long, impermeable sleeve. The proximal end would sit in the duodenal bulb and would cover about 60% of the first part of the small intestine and would not let the food absorb. Biliary complications, biliary abscesses were the prohibitive, and the trial had to be stopped, but I think another trial is under the way. Same concept, longer tube, 120 centimeter long, that will help, you would assume would help achieve the weight loss, mimicking the gastric bypass surgery. 4-pass is another similar device that has been studied on the pigs, and data on the humans is awaited. Treating the diabetes directly rather than treating the obesity by duodenal mucosal resurfacing, you would ablate the duodenal mucosa by this device. New device which does not involve heat is also available, and that will help reduce the A1C levels. And then the incision-less magnetic anastomosis system is 2 magnets. You would approach the small intestine with the enteroscopy, both from the top end and the bottom end, and release the magnets. They will find each other and make an anastomosis and will be released in the stool, and that will help you lose weight. In the first case, laparoscopic assistance was required, but I have heard that more cases have been done purely endoscopically. So a lot of options, significantly working, effective and safe medicines available at the moment, and more in the development, and that's the key message. The intragastric balloon and endoscopic sleeve gastroplasty are the current players, but I'm sure we will have more and more endoscopic methods to manage the obesity. And I think combination therapy along with some type of surgery or medicines plus the lifestyle modification will help us manage the epidemic of obesity. My contact details, if anybody would like to contact me, and I'm happy to answer any questions now or when the question time comes. Thank you. Thank you.
Thank you. It was an excellent presentation regarding the endoscopic management. So we all know that endoscopic procedures are never without complications. So I request Dr. Ghayasul Hassan, who is an interventional radiologist at Lahore General Hospital, to show us about endoscopic interventional gastroenterologist, to tell us something about endoscopic management of these complications.
Presentation. Okay, thank you very much for the kind introduction, and I'm really honored to be there, and I will be presenting the endoscopic management of bariatric surgery complications, since the obesity is on the rise, and so are the metabolic surgeries and their complications. So I will be presenting the bariatric surgery procedures, common complications, and role of endoscopy in the management. So obesity is on the rise, and an estimate shows that nearly half of the American population will be obese by 2030. And obesity carries a lot of morbidity and mortality. We can have cardiovascular risk, cancers, depression, and many other complications which Dr. Hamad has recently discussed. So these are the types of bariatric surgeries commonly being done: through and via gastric bypass, sleeve gastrectomy, adjustable gastric banding, and biliopancreatic diversion for super obese patients. But the first two procedures, Roux and via gastric bypass and sleeve gastrectomy, they are the commonest one for patients who have obesity and comorbid conditions. So this is the picture which shows the procedures of sleeve gastrectomy. Pointer chalta. Okay, so this is the sleeve gastrectomy in which almost 70 to 80% of the stomach has been resected, and this is Roux and via gastric bypass. Biliopancreatic diversion is reserved for super obese patients. So what are the common complications of these surgeries? So we can have leaks and fistulas, post-op hemorrhage, gastric fistulas, anastomotic ulcers, anastomotic strictures, sleeve stenosis, weight regain after some time, choledocholythisis with altered anatomy, as well as we had the minor complications like GERD, internal hernias, cholelithiasis, hypoglycemia, and malnutrition. So to deal with these complications, surgeon, IR, and gastroenterologist, they should all work together to deal with the complications. So anastomotic ulcers, they are the commonest cause for nausea, vomiting, and pain. They may present with a delayed hemorrhage. Usually they are within the first 3 months, and the percentage is 0.6 to 16% after ruined by gastric bypass. So the etiology is ischemia most of the times because of takedown of short gastric arteries. Foreign body reaction, like we can have retained staples or sutures at the anastomotic site. H. pylori infection. Smoking prevents the healing of these ulcers. Patient might be on NSAID for any pain relief, and patient might have fistula. So whenever we deal with anastomotic stricture, anastomotic ulcers or marginal ulcers, we should be knowing about the etiology, and we should also try to address the etiology. So these are the pictures of anastomotic ulcers. They may present with the symptoms, or they may present with the hemorrhage as well. So diagnosis is mostly endoscopic. Stool antigen for H. pylori should be tested. We should not relying much on the biopsies taken from the remnant stomach because they may be negative. So medical therapy is, we should identify the precipitating cause. We may treat H. pylori infection. Patient might be put on double dose of PPI. Sucralfate might help. And if the foreign body like staple or suture is identified at the ulcer, we might remove endoscopically. Endoscopic suturing is an option, and surgery for refractory cases. And obviously, to prevent these ulcers, we ask the patient to stop smoking. So if the patient presents with bleed, the options of bleeding, like the patient who presents with bleeding ulcer, we can have through the scope clips. Over the scope clips, we can use the hemospray if the visibility is poor, and we can resuture the anastomotic site as well. So leaks and fistulas, this is a very important complication, and I will be focusing much of my talk on leaks and fistulas. And remember, the principles of leaks and fistulas management, they remain the same for rest of the leaks and fistulas in GI management. So leaks and fistulas, they are 1% of ruined by gastric bypass, 1 to 5% of sleeve patient, and higher rates in revisional surgery. The risk of death is not related to the leak or fistula itself, but inability to obtain the timely diagnosis and management. So there is a difference between leak and fistula formation. Leak is basically communication between extra and intraluminal compartments. Fistula is basically communication between two epithelialized surface, and etiology is inadequate vascularization like ischemia, tension on the suture line, staple failure, tissue fragility, and downstream stenosis. So we need to classify the fistula and leak after sleeve gastrectomy, and they may present acute within the 7 days postoperatively, late after 7 days, chronic if it is persistent for 12 weeks, and very late they may present with weeks and months after the surgery. So whenever we have sleeve leak, we need to define whether it's a type 1, type 2, or type 3. In type 1, there is hardly any documented collection. In type 2, there is intra-abdominal abscess. And in type 3, there are internal and external fistulous communication. So we need to see where we are standing if we are dealing with a patient of sleeve leak. So majority of the sleeve leaks, they develop at the proximal staple line below the angle of His. There is an area of relative ischemia, as we discussed earlier, because of takedown of short gastric arteries, and there is a zone of increased pressure distal to the site of leak because of luminal stenosis. So in patients with ruined by gastric bypass, they can have many places where they can have the leakage. They can have leakage at the residual stomach stump. They can have the leakage at the site of gastrojejunostomy. They can have leakage at the jejunojejunostomy and in the excluded stomach as well. So these are the potential sites. So this is the patient who has presented with the leak, and the CT scan is the investigation of choice. Whenever we expect the patient to have leakage, we should order the patient to have CT scan with oral and IV contrast. And we can see that this is the patient who has sleeve gastrectomy done, and we can see the intra-abdominal abscess. This is the endoscopic picture of fistula opening. And if we inject the contrast endoscopically, we can see the spillage of contrast inside the cavity. So this, again, this picture shows the staple line and the fistula's communication indicating the leak. So how do we manage this leak? We need to take the surgeon on board, endoscopist on board, IR person, and nutritionist. So initial management, we start the antibiotics, we control the sepsis via drainage. Drainage of abscess should be endoscopic, maybe percutaneous, surgical, and we also place the jejunal feeding tube for the patient nutrition. So early treatment is the key. If we treat the patient earlier and recognize the complication earlier, the success is really 100%. But if we delay for more than 3 weeks, the clinical success is roughly 70%. So early treatment is the key. Similarly, in the patients who present with a leak, and if we detect them earlier, the success rate is 100%. And if we let the leaks to become the fistula communication, the success obviously drops down to 72%. So these are the 3 general principles of dealing with these fistulas and leaks. We close the defect, we cover the defect, and we drain the fluid collections. So in closure techniques, we have cap mounted clips, we can use the tissue sealants, and we can use the suturing devices. So there are some pros and cons of using all these things. Tissue sealants, they have the limited efficacy. If the defect is less than 10 millimeter, it is safe. Obviously, it requires multiple sessions. Cap mounted clips, they have the excellent ability to close the defect, which is less than 20 millimeter, but obviously we need to drain externally the abscess cavity, which is adjacent to this site of leak. Suturing obviously requires a lot of training, but very effective, safe, and needs a training, and someone at times it may be difficult to deploy the suture. We must remember that our conventional through the scope clips, they are not good to close transmural defects. So they are good for closing the mucosal defects, but if we are dealing with a complication where we have done the transmural damage, whether endoscopically or in the patients who have present with the sleeve complications, through the scope clips, they don't work. So this is the suturing device, and this is the Ovesco, the commonly used. We grab the defects, two edges of the defect, and we apply the clip. And 2 centimeter is the limit to which we can apply. Covering techniques, we can use our conventional esophageal stent or mega stents. They are very popular, but the efficacy is 70%. Patient might resume the feeding immediately, but the downside is high risk of migration. Patient has to tolerate the pain. And we can fix the stent with the help of Ovesco or our through the scope clips, or we can suture to prevent the migration. Cardiac septal defect occluder, I haven't ever seen or used it, but the efficacy is really very high, and they are very effective, although they're costly. So this is the mega stent placement in a patient with the leak, sleeve leak. This is the ASD occluder device and the drainage techniques. These are also very important to understand for every endoscopist, and endoscopic vacuum therapy is commonly used, very cheap. We can make this endoscopic vacuum therapy in our endoscopy unit. They have the high success rate, but obviously the patient needs repeated sessions. The bleeding is a major risk, but they have the high efficacy and very cheap. Double pigtail stents, we can place the stents, double pigtail stents endoscopically between the abscess cavity and between the stomach or any other fistulous communication. They have the high efficacy, but obviously we need to drain, doesn't require any external drainage, but we need to establish the feeding as well. Sorry. If we identify the septum between the site of leakage and the abscess cavity, we can do the endoscopic septotomy as well. So endoscopic vacuum therapy can be inside the cavity or can be inside the lumen. This is the picture which shows a large fistulous communication. This is the sponge applied at the distal end of our routine NG tube. We can place this endoscopically, and we can see that gradually this defect has closed. And usually 8 to 10 sessions of endoscopic vacuum therapy, 3 to 5 days after repeated sessions are required. So these pictures show the placement of double pigtail stent. Patient has also external drain as well. So if we see down the road after 6 weeks, we can see that this cavity has closed over the stents. So this is a really very effective therapy. This patient has a dual management placement of stent as well as mega stent. So the other common complication is stricture, and the etiology is ulceration and ischemia. So in stricture management, we need to go for balloon dilatation, but remember, we should not be over enthusiastic. We require multiple sessions, but don't go beyond the 15 millimeter and remove the foreign body. Inject with the steroids if needed, and the efficacy is fairly good. But we should not be over enthusiastic, and as we dilate more than 15 millimeter, patient might regain the weight. So these are the pictures in which we can see the stricture. This is the balloon, and this is the result after balloon dilatation. We can place SAMs or routinely a tubular stent if the stricture is short and the results are good. With the lamps, the risk of migration is less, but with the tubular stent, the risk of migration is high. We need to fix the stent. So this is the case of young patient who presented 30 days after sleeve gastrectomy with persistent GERD, foaming, and patient is not able to tolerate any semi-solid food. So this was the barium study done, and barium study was reported to be normal, and endoscopy was done, and also it was reported to be normal. But if we critically analyze this contrast study, we can see that this long segment, so this is the patient who's basically having sleeve stenosis, and we can see that this is the narrow segment. This is the narrow segment, and the sleeve stenosis, it almost always happened at the level of incisura. We can use our ecclesia dilatation balloon, and we need to be very careful that balloon tip should not be in the pyloric canal, otherwise we can have the perforation. So these are the pictures in which we have the sleeve stenosis, and we use the our ecclesia dilatation balloon. Clinical success is high. So patients, they tend to have gallstones after bariatric surgery, and it's very difficult to manage these gallstones after surgical altered anatomy. So we can go for balloon-assisted ERCP, whether it is a single balloon or double balloon. We have the limitation of different devices. Laparoscopic-assisted ERCP can be done. Obviously, patient need to go undergo surgery again, and the follow-up ERCP can be challenging if we place the stent. Edge is an option, which our dear colleague Dr. Nadeen Tehami is very expert in doing that. So this is the picture in which we can see the balloon-assisted ERCP. There are stones. We can do the balloon dilatation. Obviously, there are many limitations of using this double balloon. This is the Edge US directed transgastric ERCP, in which we place the US scope in the gastric remnant, and we puncture the excluded stomach. We fill it with the saline and the contrast. We place the lamps, and through the lamps we can do the ERCP. We can better to delay ERCP for 2 to 3 weeks for this fistulous communication to mature. If we need to do it urgent, we can fix it with the help of suture. So these are the pictures, radiological pictures. We can see that the lamp is being placed, and through the lamps we dilate it, and after the placing the lamps we can do the our ERCP. And once we have done the ERCP, we should remove the lamps to prevent this fistula to be permanent. So weight regain after ruined by gastric bypass, it is another complication, and endoscopists have the role. 20% of the patient, it can be multifactorial. Either it is dietary non-compliance, change in the gut flora, hormonal changes, anastomotic consideration. We might having gastrojejunal anastomotic dilatation, gastrogastric fistula might be formed, and high rates of morbidity and mortality are associated if we go for surgical revision. So we can go for TOR, or we can go for endoscopic sleeve gastroplasty in a patient who have sleeve gastrectomy previous surgical. So TOR shows it is very efficacious. After the TOR, 6 months and 12 months after the treatment, patient tend to lose the excessively gained weight. So we can see that the gastro jejunal anastomosis had broadened. We apply the APC to rough the edges, and after the APC, we narrow down the defect with the help of our suturing device. we can place the 10 millimeter balloon inside this defect so that we can have idea how much we are closing, and this is the effect after 4 weeks. So this is the procedure we can do. So in conclusion, most bariatric surgery leaks can be managed endoscopically. We need to have close collaboration with bariatric surgeon and IR. Internal drainage has paradigm shift in bariatric surgery management, and toolbox for managing these complications are progressively expanding. Thank you very much.
Thank you, Dr. Gaz, for an excellent talk. Next, we are going to hear regarding management strategies of non-varicose upper GI bleed. I invite Dr. Saqib, a consultant gastroenterologist from NHS UK, to please come and deliver your talk.
Thank you very much. It seems these days people die because of eating, not because of hunger. We're going to change the taste and the flavor of our topic and go to our most common topic, which is GI bleed. And particularly, we'll be talking about non-varicose bleed. And I thank Professor Hassan, Kamran Hassan, and Dr. Shair Rahman for inviting me here. So thank you once again for inviting me here. The topic I'm going to cover is non-varicose GI bleed management. This is my hospital just a couple of months ago in winter. GI bleed has been reported as far as an 11th century medieval book of Ibn Butlan. He's the guy who gave us 6 natural remedies: air, sunshine, exercise, mental health, and eating in moderation. And imbalance of these causes disease. So we're going to cover under a few topics. I'm going to try to emphasize some statistics, how to, when you see a patient, how to risk stratify GI bleed. It's important to know when to come in, whether you have to wake up in the middle of the night and come and scope the patient, or you can wait, and what is the optimal interval for scoping. Actually, does all GI bleeds needs to be admitted to the hospital, or they can be managed as an outpatient? PPI is a $1 billion industry. This year, the profit was about 13 billion, and they promote use of PPIs. But actually, is there a role of PPI in GI bleed? Whether we should transfuse or not? You should all know your endoscopy toolkit. That's going to make a difference. And actually, sometimes you can fail, and you need good IR and surgical team as well. So why we need different strategies? It's a very common medical emergency. In UK, about 90,000, 85,000 to 90,000 cases per year, which actually means one case in every 6 minutes presentation to UKNA is a GI bleed. Since Rockall first data and presentation in 1992 till now, the mortality hasn't changed. In 45 years, it's still 10% inpatient mortality of GI bleed, and that's despite all endoscopic advancements we have, all new gadgets, sprays, etc. The mortality hasn't changed. The major cause, still 50% in last GI bleed audit by UK, is still peptic ulcer disease, and that hasn't really changed despite H. pylori eradication either. Good news is, if you don't settle, 80% of non-varicose bleed does settle down itself. However, the important point I want to emphasize is 10% of these bleeds actually rebleed, and their mortality is 10 times more than in this presentation. So try to get it right at first time. So this is the data from GI bleed audit from the United Kingdom. And the major cause is peptic ulcer disease, then followed by esophagitis, gastritis, etc. Malignancy, and in 5 to 10% of cases, you actually never find the cause. And sometimes that is because there's a Dulafoy bleeder, or you hadn't had a chance to look enough, or you have gone too soon earlier and you didn't have enough view to see. And that's one of the reasons not to scope them too early. So I'm just going to present a case. Emphasis not on the case, but it's to go through that. This is a real case we managed last month. A 56-year-old man. He actually had episodes of cholecystitis 2-3 months before, had 2 admissions, and he was waiting outpatient cholecystectomy. Just to give an idea, in our area, the wait for outpatient cholecystomy is just 18 months. So, so he had recurrent admissions. He was also diabetic, had stents, coronary stents for 3 years ago. He was on aspirin, then apixaban, and because of his pain, he was taking some painkillers as well. So on his presentation, his hemoglobin was 97 or 9.7 grams per deciliter. Urea was slightly raised at 9.2, mildly tachycardic with pulse of 100. Blood pressure was relatively okay, 110/70, with the mildly deranged liver function test as well. So with this in mind, you were called at 6 p.m. in the evening when you're trying to go to home. How would you approach this patient? How would you risk stratify whether you would transfuse or not? Shall I give him PPIs? Will it save him from any endoscopic intervention? What to do about his aspirin? Do we need to reverse his apixaban? Scope, when and how? So these all different strategies we need to know. So just a quick wrap up of a scoring system. You can use any of these scoring systems. Rockall and Glasgow Bradford scores are the most common one. However, my favorite one is, which I'm going to tell you a bit later. The Glasgow Bradford score was invented in 2000 by Glasgow Royal Infirmary. Um, Blatchford, Oliver Blatchford was the research and doctor who presented this one. Their main aim actually was to risk stratify GI bleed into low risk and the high risk, and they were trying to figure out if the patients can be discharged because there's always chronic lack of beds in NHS, and whether if they are admitted, whether they can be monitored in low monitor outlier medical wards where they don't need intensive monitoring. So higher risk Glasgow Bradford score correlates with a high likelihood of needing intervention, and the score of 6 is associated with 50% need of requiring endoscopic intervention. And it's all clinical based on your pulse, blood pressure, hemoglobin, history of melena, syncope, heart disease, etc. Rockall score has two parts at admission and post endoscopy to give you a complete Rockall score. It was the first famous scoring system developed by Tim Rockall in 1992. So it's easily remembered by A, B, C, D. A is age, B is blood pressure, C is comorbidities, what is the endoscopic diagnosis and whether they have any stigmata of real bleeding or not. What is the significance? If your pre-endoscopic Rockall score is 0, you are low risk, you can wait. If your pre-endoscopic Rockall score is more than 4, then it's more likely you're going to be followed in the high risk category, and that is important because the incidence of blood transfusion, further bleeding, and mortality goes high exponentially when your score is 6 or more than high. Post endoscopic Rockall score is less than 2, and you can safely discharge these patients home. So this is my favorite one actually from Japan, from multi-center. They did trials about unselected GI bleed patients, and they only looked at 3 parameters to triage them. One is no use of PPI, recent use of PPI, if they're shocked on presentation, and if they've raised urea creatinine ratio. And I can tell you from last 15 years of dealing with GI bleeds, I only go with one parameter, which is pulse. So once you have seen your patient in emergency, and if they have after an hour of flu resuscitation, they still tachycardic, I don't go home. I sort those patients. You don't need rest of the information. Tachycardic at 1 hour, stay in and sort them out. So in nutshell, GBS score stratifies low risk and high risk patients to tell you if you need to admit or discharge patient, whereas Rockall score gives you attempt to identify patients which are at risk of adverse outcomes and mortality, and post endoscopy Rockall score of less than 3 should be considered for early discharge, that is 24 hours. And taking this further, they conducted the study and a trial where all the unselected GI bleed patients in Glasgow were admitted if they have Glasgow Bradford score of more than 1, and less than 1 were discharged as an outpatient, and they had a negative predictive value of nearly 100% with no adverse outcomes at 30 days and 6 months. So that's led to BSG recommendation that patients with GBS score of less than 1 should be considered as an outpatient urgent scope and management. Well, obviously, you need to give them a safety net advice as well. And the With the emergence of AI, the things have not stopped with these scores, and colleagues in Stanford, in collaboration with Edinburgh, London, and European colleagues, developed this AI machine learning algorithms which can predict actually better patients who will need admission, intervention, or whether who can be discharged. And in all parameters, 30 days mortality, 6 months, and need for intervention, the machine performed better than the humans. So watch this space for this. So in our case, our patient had a GBS score of 7. It means he's a high risk of having some endoscopic intervention. His pre-endoscopic recall score is 2, 5% mortality. We can tell him prior to admission there's a chance, and his Herbringer score was 1. So there's no need to rush and scope him that evening. So we can wait him. We need to resuscitate him, and we can do him tomorrow. What about his aspirin? So there's enough data. If there is aspirin for secondary prevention, that is like he had a coronary stent, there's no need to stop it. It's a safe drug to continue even if they're unstable. Colleagues, if you have actually decided to stop, then please don't forget to restart at 5 days, because if you forget, it never gets started, and the very higher incidence of cardiovascular mortality in a year and 5 years' time. So, message is you can continue aspirin. What about antiplatelet agents and DOACs? So, ESG has a detailed guidance on that. If you have unstable bleed, you can continue aspirin, but you can hold off clopidogrel. But don't forget to restart at 72 hours to 5 days, depending how the patients go. With DOACs, is the similar. You don't need to reverse DOAC or apixaban, etc. with the agents because they're very expensive. They are short-lived. Most of them are cleared from the system from 12 to 24 hours. You can wait and scope them next day. If you're worried, you can give them FFPs or PCC factors, etc. So the message really is bleeding is safer. All bleed stops, but the main cause of death in GI bleed is not bleeding; is actually cardiovascular mortality, which is high at 30 days if you stop their anticoagulants. And the next important question is, what is the data about timing of scope? So there's no need to rush and just put the camera down, because all you see is a bloodshed and a bloodbath, and you won't be able to do much. So in this study, particularly they looked at the patients with peptic ulcer disease and divided into two categories: the ones who are stable and the ones who are unstable. So if you're fit and well, gentlemen, like Dr. Thami, who walks at night miles and come home, you can scope them at 12. You can scope them anytime, which doesn't make difference. But if your ASA status is 3 to 5, the optimal duration of scoping when they do well is 12 to 36 hours, and similar 12 to 24 hours for unstable patients. And that is because the resuscitation is done poorly. If it's done adequately, no one needs an urgent scope as such. And similarly, colleagues from Hong Kong and China looked at unselected nearly 7,000 patients. The first study was in patients with peptic ulcer disease, and this one was unselected, any cause. And they divided them into urgent, early, and late endoscopy, which urgent less than 6, early 6 to 24 hour, and late in 24. So they found out that urgent and late groups did bad in all three parameters: 30 days mortality, repeat endoscopy rate, ICU admissions. And the conclusion from their study was the best interval is 6 to 24 hours to scope these patients. Resuscitation is the key. Coming back to our case, do we need to transfuse him? But this has hemoglobin of 97. This has been answered widely by the trial published in New England Journal in 2013. They divided into liberal and the restricted group, and guess what? The restricted group did very well rather than the liberal group. So unless you've got a really hosing patient who's unstable, you don't really need to transfuse these patients. So in our case, no blood transfusion was given, but do we need to do something else? I mean, we are pushed to give PPIs. What is the evidence? Do we need to give before scope, after scope, whether IV or oral, or what is the duration of PPIs? So that's why we call them the good and the bad and ugly in upper GI bleed. The take home is there's 21 RCTs, nearly 3,000 patients. If they have, or if you clinically diagnose them peptic ulcer disease, PPI treatment peptic ulcer disease reduces rebleeding and surgical intervention rates, but has no effect on mortality. So you can use them in that context. However, in unselected GI bleed, there's no evidence that there's the PPI IV or oral does any difference in mortality, rebleeding, or surgery. However, you're less likely to find endoscopic therapy in this groups. So if you have if you don't suspect peptic ulcer disease, there's no need to use PPIs. What about IV bolus? Is it as good as oral, high dose oral? And actually, we all were persuaded by the Hong Kong trial a few years ago to give IV infusion 72 hours and then 8 milligram per hour. But actually, there's no difference in mortality if you do use oral high uh, oral high dose BD if the patient is able to tolerate oral. So that led to the conclusion of NICE, which is in England, that they want to save money and increase incidence of C. diff. They didn't recommend using pre-endoscopic PPIs, but only use if you find peptic ulcer disease on the endoscopy. However, ESG was more liberal, and they recommended intravenous high-dose PPI followed by infusion. I'm going to a little bit rush because of the time. One of the problems I face is if you go and in a major bleed, you find a stomach full of blood, and how you can improve that is I, in practice, try to give them a dose of metoclopramide when they present in the A&E. It has two effects. It improves visualization of the stomach, and you're more likely to find the cause of bleed. And it also helps in variceal bleed. It causes spasm at GOJ, gastroesophageal junction, and bleeding varices are less likely to bleed with 10 milligram IV of metoclopramide half an hour before endoscopy. So once you are in, you need to know what equipment you have. You have lots of varieties these days. We're not going to go into details. You can use injections. You have options of using heat, mechanical such as clips, over the scopes, clips, ligation, and now we have bailout options with hemospray or Purostat as well. Once you know variceal bleed, you should be able to risk stratify, and the most common use is a Forest grade classification. The one with Forest 1 to 2B are the ones who need some kind of endoscopic therapy. The rest of them doesn't need endoscopic therapy. They can just be managed with PPI infusion. Once you using endoscopic hemostasis, know your team, know what your tools, apply them effectively, but use combination therapy. The best data is two modalities, either injection or clips, or injection or APC or heater probe. The dual modality has better outcomes than a single modality. Only, however, there's recent data emerging about the OVESCO or over-the-scope clips for especially with a visible vessel. A single over-the-scope clip is good enough as dual therapy as well. Now, once you've done the endoscopy, the main strategy you need to know is write a good endoscopic report. Because of the busy schedules we have, you might not be available tomorrow. So you should emphasize on the re-bleed plan. You should photo document, and you should make a plan when they should restart their anticoagulants and how long you're going to give them PPS for. That's all the endoscopist responsibility. So our case, we scoped them next day, and this is what I found. This is actually ampulla with a slow oozing ampulla blood, which is called hemobalia. The rest of his stomach was fine, so we switched over scope to ERCP scope because if you remember, he was a bit cholangitic and with raised bilirubin as well. And this shows these filling defects in his CBD. So I thought this looks a bit odd, doesn't look like stones. So we did cut, and then we did a balloon trawl, and we removed lots of clots. So he essentially was bleeding inside his biliary system. So what are you going to do next? You should call a surgeon or a IR. I think we went for an option with IR. We had a discussion with the HPB team. It's important to have that strategy in mind. Just going out of this context, rebleeding occurs in about 10 to 20% of cases. Rebleeding depends on your Forest classification, your skills, and how effectively you have used your tools. And if the endoscopy fails, or if there is an atypical cause like hemobalia, you have got an option of IR or surgical. In our case, we went to IR. We did a CT angio first. This shows the gallbladder. So he was slowly oozing from the aneurysm of the cystic artery, and the blood in the gallbladder was causing a was containing it. The IR attempted it. They tried to embolize the cystic artery, but that failed due to the anatomy. It actually caused the cystic aortic puncture. So, in fact, sometimes interventional radiology can make it worse. So, he ended up having a surgery and removal of his gallbladder and cystic artery. So hence IR is not always a magic solution. Although they claim to have sometimes success rate of 90 to 100%, the clinical success can vary from 50 to 90%. Rebleeding is high, sometimes from 10 to 40%. Ischemia is one of the issues you need to consider, especially in your elderly patients with arteriosclerosis and other risk factors. If IR failed, only option is surgery. Only point I want to emphasize is the best surgical outcome is in the stomach with a of the bleed is in esophagus, calcified or endoscopy because IR surgeons can't really help you. Duodenal IR is preferred over surgery. So in interest of time, the 6 basic strategies recommended by BSG and NICE is recognition, resuscitation, resuscitation, resuscitation. I cannot emphasize enough. Risk assess, treat them, refer them, and review them. So, and key takeaways is rapid assessment, resuscitation are critical for GI bleed. Endoscopy is primarily diagnostic as well as therapeutic. Multidisciplinary approach is needed. And the main thing I want to emphasize is think of quality, get it right first time, because if you fail, the rescope has 10% mortality, and keep calm, all the bleeds settle down eventually. Thank you. Thank you very much.
Thank you so much, Dr. Saqib. It was really an excellent presentation. So next to talk about the most popular bug of the GI tract, H. pylori, I invite Dr. Ishfaq Ahmed to please come and deliver your talk.
Bismillah ar-Rahman ar-Rahim. I'm very grateful to the PSG organizers, Dr. Kamran Hassan and Professor Sher Rahman and the PSG organizing team for this kind invitation on this prestigious event. This is my second time in Peshawar, and I was looking at the photographs of my last presence here, and actually I was wearing the same suit, and they have fed me so much that I couldn't wear this suit for the next 3 years. So it took me a year to lose that weight. So I've already gained 2 kilograms since yesterday. So thank you very much for all your kind invitation. My specialty basically is a little bit of colonoscopy and training in colonoscopy. So I was scratching my head a little bit. I hope I can do some justice with the topic. So first of all, if I can wake you up, I mean, some people at the back are sleeping a little bit, talking and discussing at the last row. Can I just have a show of hand, please? What's the commonest test you use, non-diagnostic test for diagnosis of H. pylori in your practice? Is it, raise your hand, is it urea breath test? There are a few hands at the back. Blood test for H. pylori antigens? No show of hand. Oh, there are a couple. Fecal H. pylori antigens? Majority does the fecal H. pylori antigens. So before I go on to my talk, I'm just going to take a couple of minutes. Oh, no, I've lost a few minutes already. So we'll start the talk. So H. pylori infection is the commonest cause of peptic ulcer disease and also is associated with gastric cancer. So the topic I was given, management East versus West. So I've got a mixture of East, little bit of UK and little bit of West. So the management strategy for H. pylori infection is based on the prevalence of the infection, and also the risk of gastric cancer in that area. And the thirdly, antibiotic resistance, which is quite a major challenge coming up. So I managed to pull some figure out for H. pylori resistance. I think if we don't name these two guys, that would not be a credit to these two guys. Actually, in 1979, one of them is pathologist Robin Warren, actually discovered H. pylori on the gastric biopsies, and a year later they named it H. pylori. But in those days, perhaps, I'm not sure, they couldn't do any kind of randomized trial. His colleague gastroenterologist actually ingested the infected material from a patient or from a culture, and he developed acute gastritis, which was confirmed on histology that it is due to H. pylori. So they've done a marvelous work. Previous dogma was that peptic ulcer is associated with stress and hyperacidity, which is still the case. I think a lot of, when we don't know much why the patient developed peptic ulcer, we say, oh, it is stress, your stomach is producing a lot of acid. So these two guys has done a wonderful job, and they then got the Nobel Prize for Physiology in Medicine in 2005. Well done, these two guys. So next come to the prevalence of H. pylori. The light brownish color areas where the prevalence is unknown, and yellow area where the prevalence is less than 20%. And these area in dark blue, the prevalence is around 80 to 90%. So I think I usually find India, and we are next to Pakistan, so we are around 70 to 80% prevalence, or maybe a little bit less in our motherland. So there are various studies. I think there was a tertiary center studies from Karachi which showed a patient presenting with dyspepsia or peptic ulcer bleed. I think they done all the possible tests they could do, including UHB, urea breath test, and they found that the prevalence is around 7.9%, but the prevalence in the population ranges from 40% to 75%. Depend on if you go to a very posh area of Peshawar, which is Hayatabad, I think, the prevalence will be low, but if you move out of the Peshawar into the villages, the prevalence will be very high. So the diagnostic test, we have already have a brief snapshot of your practice, that you're all commonly using fecal H. pylori antigens, but I still get some results from Pakistan with blood tests showing positive antibodies, which cannot actually tell that the patient has got active infection or the past infection, although some results comes with the IgG levels as well, and those patients are found to have fecal H. pylori antigens negative. So I think the standard, I would say, first line test, what I guess from you is fecal H. pylori antigen. Then we are moving on to the invasive test. The most commonly test we use is rapid urease test. It's called a CLO test. Virtually anybody in United Kingdom coming in for endoscopy gets the CLO test. It's a pathetic test to be done. I think sensitivity around specificity around 70%. Only reason they don't do the CLO test if the patient has been on antibiotics or on PPI prior to endoscopy. Biopsy we do in some cases, the patients which are on antibiotics or PPI, in those cases we do the biopsies. Culture, we keep it reserved for patients who are very resistant to various antibiotics, and they have had a few treatment already which has failed, and then we do the culture to see what antibiotics they can benefit from. PCR is only done at this stage at the research levels only. What is the source of H. pylori? We are the reservoir, and from the various places H. pylori has been isolated. And the transmission is orofecal route, so it again depends on hygienic condition. That's why in a good area or affluent areas, the risk of infection is low compared to the low socioeconomic areas. So what can H. pylori do to us? With acute infection, there will be superficial gastritis, which can lead to chronic active gastritis, predominantly involving the antral region, and it can cause duodenal ulcer. That is the reason that we take the biopsy for urease test at the time of endoscopy from antral region. So the second, in some patient can get chronic active pangastritis with some atrophy. That increases the risk of gastric ulcer. And the last one is a dreadful, is a gastric cancer. So accuracy of the blood test is, I think the gold standard is still the urea breath test, but it is very, very time consuming. And after COVID, and I haven't seen anybody doing this urea breath test in UK. And the fecal H. pylori antigens are second best tests, and they are commonly used. Urease test at the time of endoscopy is a kind of very pathetic test, but every patient in UK gets that test done. So what are the association of the H. pylori infection? Peptic ulcer disease is proven, bleeding peptic ulcer or normal peptic ulcer disease, gastric atrophy, malt lymphoma is definitely associated with H. pylori infection, and then it's one of those cancers which are very gratifying, that you give them antibiotics and you cause them cure. Other possible association are the patients who are taking non-steroidal anti-inflammatory medication. If they are HP positive, the risk of complications are higher. Some weak link with the non-ulcer dyspepsia, although all the patients with non-ulcer dyspepsia, about 25-30% will have HP positive. They are being eradicated. And there are a few rare conditions where the association links are still a little bit weak. So the major factor is that we have got very liberal availability of antibiotics, perhaps in our motherland. Antibiotics availability in UK is very, very limited. Even if I have to have some antibiotics, I have to ask a friend to write a prescription for me. So I cannot go to the chemist and get an antibiotics directly. It has to be on a prescribed basis. So amoxicillin resistance in the West is still very low for some reason. Compared to in Pakistan, it's around quarter of the patients will have amoxicillin resistant. Moving on to clarithromycin, the resistance is increasing in the West, and in Pakistan around 39 to 40%. And the last antibiotic is metronidazole, which is now hardly ever used because in both East and West, the resistance is very high. So I was searching the literature, and I was this morning at the breakfast, I was asking one of my very good friend across the pond, transatlantic friend, and I asked him, how do you treat H. pylori? He said, just tell the nurse, give her medication. So I think in Pakistan, I gather that moxifloxacillin based PPI plus amoxifloxacillin and amoxicillin for 14 days. I very much doubt that the patient will be taking 14 days, I think, due to the side effects, but that is considered to be quite good, 86% eradication compared to 67% with clarithromycin-based therapy. So what are the difference between East and West? In East, particularly Japan, Korea, our friend is from Japan, where the prevalence is high and the prevalence of gastric cancer is very high. So there is a routine screening of the population for H. pylori and eradication, mass eradication. Those who are found to have H. pylori positive, they get eradication treatment. And after eradication, there is a policy that they should be retested to make sure the H. pylori has been eradicated. In the West, there is no kind of mass screening at all. It's only the patient which attends your clinic with dyspepsia or attends to the GP, or patients attending for gastroscopy. The H. pylori is tested in those patients. There is no routine screening of the population in the West. And obviously, patients with the maltoma, we make it every effort to test them for H. pylori with one of the best tests available for us. And we also make sure that after the treatment, we retest them to make sure that the H. pylori infection has been eradicated. The only precaution is that when you retest them after the treatment, the patient should not be on PPI for 2 weeks and antibiotics in the preceding 2 weeks, although there is a recent paper published showing that PPI does not make any difference. So the first line regimen in the East is more moving towards quadruple therapy, including bismuth, PPI, tetracycline, or metronidazole, and clarithromycin-based triple therapy is avoided due to high resistance. In the West, clarithromycin-based triple therapy is still used in some area, and quadruple therapy recommended in regions with a high antibiotic resistance. So antibiotic resistance in East is high for clarithromycin and metronidazole, and also in the East, the bismuth, addition of bismuth does help. We sometimes do add bismuth, but there is some supplies issue since we got out of the Brexit. Every few months there is some shortage of medicine, because the medicine produced in the European community is for the consumption for EU countries, and anything left over is given to United Kingdom. So there is a huge issues with availability of various medicine. Recently, we didn't have a lignocaine spray for gastroscopy, and we were told to use the sedation instead. In the Western Europe, increasing clarithromycin and resistance, and also there is a shift of moving towards the quadruple therapy. These resistant of antibiotics is variable in the various countries, so we cannot actually make a presumption that East is this or West is this. I think most countries, they have their own database for antibiotic resistance. Post-treatment testing, as I said earlier, in the East, they definitely do retest the patient with the fecal H. pylori antigens, or urea breath tests may be preferred to reduce the risk of gastric cancer, as the prevalence of gastric cancer is high in those areas. In the West, we never used to retest, but the new guidelines have come out that patients with duodenal ulcer or peptic ulcer bleed, gastritis, or duodenal ulcer, we should be retesting them 8 to 10 weeks after stopping the PPI for 2 weeks. And obviously in multiple lymphoma, we definitely do test every patient. So gastric cancer prevention obviously is a mass screening in high-risk area, and regular screening follow-up is recommended. And in West, that screening does not happen. It's based on the patient's symptoms, and there is no because the risk of gastric cancer is not that high. So we just simply treat the patient, whoever comes in our way. There is no mass eradication program in the West. So in conclusion, ladies and gentlemen, management of H. pylori significantly varies between East and West. East prioritizes mass eradication and quadruple therapy due to high gastric cancer risk. West focuses on symptomatic treatment and is gradually shifting towards quadruple therapy. Understanding the regional differences helps to optimize the treatment strategy. And that's all from me. Thank you very much for listening. I hope I have done a little bit of justice with this topic. Yeah.
It was a very nice and informative presentation, sir. Next, I invite one of the eminent professor of gastroenterology and medicine of this province, Professor Javed Iqbal Farooqi, who has more than 100 original articles, and he has been member of all the local guidelines. Sir, please deliver your talk on updates on management of functional dyspepsia.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Umar, and welcome all friends from abroad and all cities of Pakistan. Riyaz bhai, assalamu alaikum. Wasim bhai and Saleh. Well, Kamran rang me probably a couple of days before this conference. My lecture given to me will be tomorrow. कि जी डिस्पेप्सिया पे आपने वो कर लेना, एक स्पीकर मिस हो रहा है. तो मैंने कहा ठीक है जी कर लें. जो है ना वो मुझे तो एज अ स्टम्पनी जो है ना, आई होप कि आई मेक जस्टिस विद दिस. मैं जब आया तो मुझसे पूछा कि या मॉर्निंग में गैर हाजिर थे. नो, आई वॉज लिसनिंग टू ऑल द लेक्चर्स एंड व्हाट अ ग्रेट लेक्चर दिस वॉज. तमाम मैंने सुने. हमारी एक मीटिंग थी तो उधर मीटिंग भी थी साथ में, जो है ना मैंने ये भी लगाई हुई थी. तो वी आर जस्ट डूइंग दैट वे. Well, the topic given to me is the update on the management of functional dyspepsia. काफ़ी पोर्शन जो है ना वो जो ऑर्गेनिक का है वो शफाक भाई कर चुके हैं. तो जब कुछ भी ना मिले तो फिर हमारे पास बात आ जाएगी. Well, just to the target audience, just tell me, any medical students here? House officers, raise your hands. सर मैं चले जाता हूँ वकार भाई. So the PGs, I suppose majority are the PGs from medicine and gastro. Well, we all know, though from Pakistan, it's a grave and there is no data for the uninvestigated dyspepsia and then the functional dyspepsia. But we know that this is one of the common scenario or common presentations. I don't think कि कोई यहाँ पे दावा कर सकता है कि हमें dyspepsia नहीं हुआ. कम से कम आज के लंच के बाद तो डेफिनेटली हुआ होगा आप लोगों को. तो it's a common issue. And we start from the case scenario for the PGs. If you are here, 38 years old female presents with a 6 months history of persistent post-meal fullness and early satiety after normal sized meals. Symptoms are bothersome enough to interfere with daily activities and social life. She denies weight loss, vomiting, dysphagia, GI bleeding are alarming features. Her bowel habits are normal. The common scenario we come across, the physical examination unremarkable. Routine lab, CBC, LFTs, TSH within normal limits, H. pylori negative via stool antigen test. अभी आपने बताया कि this is the most common test we imply. Upper GI endoscopy was done by her doctor and normal mucosa, no peptic ulcer. It was normal findings. Abdominal ultrasound, no organomegaly. So the Rome 4 criteria fulfill the postprandial distress syndrome criteria as a subtype of the functional dyspepsia. Case number 2. 45 years old male, presents with epigastric pain and burning sensation, often worse on an empty stomach and partially relieved by food or antacids. The pain is not related to defecation and not associated with nausea, bloating, or early satiety. No red flag symptoms such as weight loss, anemia, or GI bleeding. The workup, physical examination, mild epigastric tenderness, no masses or organomegaly, labs all normal, H. pylori test positive, confirmed by urea breath test. Upper GI endoscopy normal. So the diagnosis was made epigastric pain syndrome. Though H. pylori was positive. कमरा ने बड़ा टफ टाइम दिया मुझे नो कि जब वो लेक्चर करते हैं तो मुझे काफ़ी पढ़ना पड़ता है तो आई हैड टू गो थ्रू ऑल दीज guidelines, the 2017, then the 2022, the apostle. My lecture, don't worry, इसका सिर्फ लुबे लुबाब आप लोगों के साथ शेयर करूंगा. So if anyone interested, you can go to these and you must read these very comprehensive guidelines. By definition, functional dyspepsia is the chronic dyspeptic symptoms without any identifiable structural cause. Again, word structural cause on upper endoscopy. Two types we just discussed: postprandial distress syndrome and epigastric pain syndrome. And there's a big overlap between these two. The postprandial distress syndrome and epigastric pain syndrome, and there's overlap between these two. And this overlap is quite evident from the world data as well. Overall, 9%, the global, and you see both these are the comparable with the overlap is here, 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 here. What should be the diagnostic approach? If there are red flags like weight loss, bleeding, anemia, vomiting, dysphagia, or age over 60 and of recent onset, we take care because of this. We know the Afghani people, they have got a lot of them, they have got the upper GI malignancy. So even if my patient is Afghani, age more than 50 will be an indication for me to undergo, to suggest the endoscopy. So immediate endoscopy to exclude the organic cause. Otherwise, if age is 60, these are the guidelines, but here, as I said, depending upon the nationality, for Pakistani probably 55, for Afghani less than 50, and no red flags, non-invasive H. pylori testing, and you treat that. And there are a lot of contributing factors, no time for me to go into that, we know all that. The treatment options for dyspepsia, the functional dyspepsia we're discussing, it's test and treat H. pylori. This is the one option. Acid suppression therapy, prokinetics, neuromodulators, and psychological therapies. And if a patient comes to you with a functional dyspepsia, you have to apply most of them. If not all of them, most of them are, majority of them. The test and treat H. pylori strategy, we do the non-invasive testing, urea breath or stool antigen, treat with standard triple or quadruple therapy, and of course eradication can relieve symptoms, not necessarily relieve symptoms in a subset of patients, and then reassess symptoms after eradication. This should be the approach in this option for functional dyspepsia. Regarding acid suppression, we know we all use them. PPIs, different types of PPIs. If the patient is intolerant of PPIs, H2 receptor antagonists. But we mostly try and go for the PPIs. What about the prokinetics? More effective for postprandial distress syndrome. The options include domperidone, but it's limited by the cardiac side effects, itopride, metoclopramide, and procalopride has been used as well, the off-label use in some regions. Coming to the neuromodulators, in my practice, this is almost the essential component or integral component or persistent component of treating these patients. Usually in refractory cases, and the patient who come to us, they are already refractory. They have been to so many doctors. So the tricyclic antidepressants and the SSRIs, SNRIs, all these we use from patient to patient. And most of the times when a patient comes, whatever the patient has not used, we prescribe that. So this is the Hatton trial. Coming to the psychological therapies, yes, of course, cognitive behavioral therapy. One of our colleagues, Dr. Shabir, is in Hyderabad Medical Complex Gastro. He is working on it. I don't know whether he's present or not, but Dr. Sher Rahman is his colleague. So he's working on this type of the therapies, the gut-directed hypnotherapies, and the mindfulness and stress management. All these are very, very important, and you must include these in your options. The dietary and lifestyle modifications, another essential component of treating functional dyspepsia patient. They should avoid trigger foods, fatty, caffeine, spicy. It depends upon the patient. And they do realize that when I take this food, it troubles me. So I tell them, okay, don't eat that, avoid that. Then eat small frequent meals, low FODMAP diet, trial, smoking cessation, and stress reduction. All these are the different lifestyle changes. What about the emerging therapies? Ecosamide. This is the promising prokinetic for postprandial distress syndrome, and now we know it's available in Pakistan. Buspirone, ghrelin agonist, these are under investigations, and herbal agents. Different people are using different, and these are probably the therapies for the future. Follow-up is very important of these patients. And remember, these are the patients who do the doctor's shopping. When they come, they bring this much big bundle of the prescriptions and investigations. And really, at times, it's very difficult for you what to prescribe, how to counsel that patient. If the patient is under your treatment, you start with the treatment, reassess symptoms every 4 to 8 weeks, and counseling is very important. And of course, at the primary care physician level, referral to gastroenterology for persistent symptoms, alarms, features, or significant impact on quality of life. They should be seen by a proper gastroenterologist. Okay, this brings me to the last component, that what's new in 2025. And I intentionally added this component because there's a couple of pharmaceuticals who are pressing upon these new molecules. So I wanted to share with you that what's the true power of that, and whether it should be used in each and every patient, or it should be used with caution. And that's the ecosamide. Now everybody is saying that, okay, we are waiting for this drug and probably it is going to solve each and every, case problem of each and every patient. It's not so. But it's a powerful tool. It's a prokinetic agent. Mechanism of action is it enhances gastric accommodation and emptying by inhibiting acetylcholinesterase activity at the synapses, and increasing acetylcholine levels at the neuromuscular junctions. And its primary use is in the postprandial distress syndrome, the first case I shared with you. This is very important. This is the initial trial in 2011 or 12, when in Japanese they found that to determine the efficacy of ecosamide, and they found that over 4 weeks the ecosamide significantly improved symptoms, severity, and eliminated meal-related symptoms. And then another trial, when you go through the trials of this molecule, is the European trial, where they evaluated in the long term its efficacy, and they found that this was the phase 3 open label trial, that yes, it was found to be effective on PDS, postprandial distress syndrome symptoms, using the validated different questionnaires. So it's significant symptom relief in postprandial distress syndrome. This is very, very important. And it improves early satiety, post-meal fullness, and gastric mortality. The dosage is 100 milligram 3 times a day before meals. Duration 4 to 8 weeks. Well tolerated with minimal side effects. The side effects, common side effects, it's the nausea, diarrhea, and headache. It's a prokinetic, so it's expected from this drug. No significant cardiac or CNS side effects, and safe for short to medium term use. Place in therapy, what I see, and the study suggests postprandial distress syndrome, alternative to traditional prokinetics, and useful in these two conditions. It has got limitations. It's not widely available in all countries. In Pakistan, this is the recent molecule they have launched. The cost accessibility may be a barrier. It's not a cheap drug. On average, probably 40 or 50 rupees per tablet it costs. And more global large-scale trials needed for guidelines inclusion. It's not among the guidelines, I must say this. And there are a couple of prokinetics like ecosamide, domperidone, metoclopramide, mosapride, prokilopride, etopride. So its mechanism of action is different from these. Indications are a bit different. This is then functional dyspepsia, PDS type, and this is the other indication for the other. When hopefully in the post-conference workshop, if we can have, we can discuss all this in detail. Time will not allow me to go into the detail of all these. Dosing is different as compared to the other prokinetics. Of course, adverse effects, it's relatively safe, but it does have. Similarly, the key advantage is that ecosamide is no dopamine antagonism, domperidone, good for nausea vomiting, metoclopramide, strongest antiemetic. So every prokinetic has pros and cons, powers, and its drawbacks. The key disadvantage is again different from that. So in conclusion of this section, ecosamide is a promising new option for postprandial distress syndrome, safe, effective, and well tolerated, part of a multimodal strategy. So coming to our case histories, this was the case history number 1. So what should be the therapeutic strategy in this case? The postprandial distress syndrome, lifestyle modification, small frequent meals. You should advise to the patient to have these. Avoidance of fatty foods, carbonated drinks, and late night eating. Weight loss if overweight. Coming to the pharmacological treatments for this postprandial distress syndrome, prokinetics, domperidone, etopride, ecosamide. Low dose tricyclic antidepressants can be tried, buspirone, and psychological support. And of course, best prokinetic choice will be ecosamide. Target gastric accommodation of dysfunction, do not affect dopamine receptors, works better than mosapride or domperidone. And coming to the case history number 2, which was the epigastric pain syndrome. What should be the therapeutic strategy for this? H. pylori eradication, acid suppression therapy, neuromodulators, non-pharmacological options, stress reduction techniques, dietary triggers avoidance, consider psychological therapies. So, dear colleagues, the key takeaways, and I'm giving you Umar 2 minutes, so another speaker can have the luxury of 2 minutes. So, functional dyspepsia is common but manageable. We need to tailor therapy to the subtypes, and this is very important. Whether it's a postprandial distress syndrome, or this is the epigastric pain syndrome. And combine pharmacological and lifestyle strategies to get the best results. And refer the patient if the symptoms are persistent or if there are alarm features. This is my message to the juniors and to the primary care physician, if they're around, that which patient should be referred for the further or advanced workup, including endoscopy. With this, I pay you thanks for the kind listening, and if there is any question, we can answer that. Thank you very much.
Thank you, sir. Your presentations are always beautiful. The next speaker is from USA. He is the President, Advanced Gastroenterology Associates of Kansas City, Dr. Syed Faisal Jafri. Sir, please come and tell us how to proceed when we see gastric polyps on endoscopy.
Thank you very much for giving me this opportunity. I thank the PSG organizers for having me here. I've absolutely loved my stay in Peshawar, and I think I've also gained 2 pounds at least in Peshawar in the last 2 days. So I'm going to have to work and get fitting my suits till the next time. The other question I was figuring out, why am I in this session? I'm an advanced endoscopist and gastric polyps, and they were talking about H. pylori. I think it's very enlightening how the organizers have put this talk right here because of the H. pylori prevalence, which is associated with these gastric polyps. So we'll try to talk about these things today and get forward. So gastric polyps are actually the most common finding, which you find incidentally when we do an endoscopy. Very rarely is an endoscopy indicated to find gastric polyps. You're doing it for GERD, you're finding gastric polyps, you're doing it for Barrett's and you're finding gastric polyps, or patients have dyspepsia and you're finding gastric polyps. So it's typically not a reason for doing an endoscopy. And the first questions which come to our mind is, what do I do with this polyp now? Is it cancerous? Is it precancerous? Do I need to resect this? Do I need to take a biopsy? Or what do I do with it following up? Do I need to, do another scope to find out what to do? So these are the questions at least which come in my mind, and I'm going to try to address them in that manner. So taking a clue from Dr. Saqib's talk, I also decided to break these polyps into the good, the bad, and the ugly. So the good polyps are the typical gastric polyps you found. They are usually benign and don't need any workup. You may or may not want to do a biopsy. And then the polyp mimics, which is the ectopic pancreas that you often see, which don't need anything. But then these are the bad polyps, which are the syndromic gastric polyps, hyperplastic polyps, gastric adenomas, and the GNETs and the type 2 gastric adenomas, hematomas, intestine. You'll see there's a common theme in here. Most of them have an H. pylori correlation in these. So that's why they're put in this bad category than just category that you can just avoid. And then these are the ugly ones, which do definitely need a much more closer look and could have devastating consequences if not managed properly. So in order to go through them, I will kind of decide that. So again, the etiology and the reason for polyps are different in East and West. So in the Western world, the most common cause of polyps is gastric funded polyps. On the Eastern world, it's the hyperplastic polyps. And there's a common theme between this East and West difference. And number one is H. pylori, and number two is PPI use. So as I was hearing through this conference, this may be shifting into there's a very high incidence of PPI use within the Eastern world as well. So maybe we'll start seeing more gastric fundic polyps in Pakistan as well. But the most common cause that I could find from the literature are the hyperplastic polyps and the adenomas, and then gastric fundic polyps, and then gastric nets that you found. So just a brief summary, gastric fundic polyps, they are usually found just like this picture over there, multiple small polyps, usually less than 1 centimeter in size. They're the most common polyps that we see. And they're usually due to dilation of the oxyntic glands. Basically, the theory is when you give PPIs, these acids is blocked, and now these oxyntic glands are just in hyperdrive trying to put out this acid and cannot. They're usually located in the body in fundus. Rarely can we find them in the antrum, and they are often due to PPI use or a hypergastronemic state. Usually PPI also is a cause for that too. There's interestingly an inverse relationship of gastric polyps to H. pylori. The lower the incidence of H. pylori in a community, the higher the incidence of fundic polyps you find. And interestingly, if you eradicate H. pylori, the chance of getting gastric polyps, fundic polyps increases. So again, on the morphology, they look multiple, smooth, translucent, with kind of just like the light shines off it when you do an endoscopy, and they're sessile, usually less than 1 centimeter, and they're rarely symptomatic. What do you need to do? You can either leave them alone, or if you're sure that this is fundic polyps, or you can do a biopsy to confirm that you're dealing with gastric fundic polyps, and then move on. And then think about maybe switching over to a less efficient PPI, decrease the PPI use, or other therapies we may talk about. But at the same time, once in a while you see this. There's just a whole carpet of these fundic polyps. And if you see that, you start thinking about, are these the bad polyps? How are they bad? And when you start seeing this, the biggest thing you see is they can also have dysplasia. Fundic polyps, which are due to PPI, rarely have dysplasia, but when you biopsy these, they can show low-grade dysplasia. And that low-grade dysplasia may not be actually low-grade dysplasia. It's just the crowding of the cells that you see on the epithelial side. But at the same time, this brings up the alarm and find out, what are we dealing with here? And at this time, you should be starting to think about, these are associated with syndromic, some sort of syndrome. Most common cause is FAP, and I have several patients that I follow for years who got this kind of pattern and have fundic polyps that we are resecting, because most of them are more than a centimeter in size, and they are recommended to resect them. They are often associated with dysplasia. As I said, they're usually 1 centimeter in size and should be resected. And they need surveillance. You cannot just stop seeing these people, and then they will recur, and then you have to keep kind of put them on a surveillance plan. And once you see this, always consider, because now we've got an FAP in the differential diagnosis, they should have an endoscopic evaluation of the ampulla to look for adenomas. And I have several patients that I've been following for fundic glands, and I've done ampulectomies on them during their life history, and do a colonoscopy. Now, I just had a patient just very similar to this picture that I showed you last month, who had multiple polyps just like this. He was referred to me from outside. First time I saw her, and I said, she doesn't have FAP, she doesn't have any mutations. But when I got into the history, I found out that she was about 55. She's had 4 colonoscopies done every 3 to 5 years, and he's always found to have advanced adenomas. And on her family history, her mother died of endometrial carcinoma. So get into the history, because you will find these FAP or these Lynch syndrome patients which are in this category of patients. So important just not to just call them as fundic gastric polyps. So how do you manage them? You do a biopsy of the few of them. If you find dysplasia, you start resecting them. If they are, if they're more than 1 centimeter or more than 20, they should be resected because there's risk of dysplasia. Again, consider PPI reduction, check a gastrin level, and then, if they cannot be brought off PPIs, maybe consider an anti-reflux procedure. And I have seen patients, fundic gland polyps decrease significantly after an anti-reflux procedure. So these are the mimic. They look like polyps, but there's got nothing to do with the polyp. They usually are arising from the posterior wall. Submucosal lesions, and have a central pit in there, which is basically an ectopic pancreas. I can tell you that I don't do any EUS for this on my own patients, but I get a lot of referrals from my gastroenterologist friends who think this is something bad and then end up doing an EUS. And they typically arise from the submucosa. And they can, if you look at it, there's a slight invasion into the submucosa, but this is all more inflammatory. And if you look closer at a higher frequency, you can see some ductal structures within it. So it kind of rules out, does not need to be resected unless they're symptomatic. Otherwise, 99% of them you can just leave alone and don't have to do any follow-ups. On the other hand, these gastric hyperplastic polyps, which are more common on the eastern side, they are also considered to be benign. They come from the foveolar cells. And in this case, there's typically a hyperproliferation of these foveolar glands due to chronic injury, either due to bile acid reflux, H. pylori, or previous surgeries. They've had a Billroth 2 or a Billroth 1, and as there's an anastomosis, continued bile acid can cause these fundic polyps to grow in this area. Rarely they can present as gastric outlet obstruction, and that's often a presentation that we see as they start having intermittent nausea, vomiting, and undergo an endoscopy. And these polyps are basically ball valving into the pylorus and causing an obstruction. Now, if that's the case, you should resect them. Etiology, again, is from mucosal atrophy. which is most probably due to H. pylori and or atrophic gastritis. So you have to look for atrophic gastritis in these patients, and some rare correlation of this being with IBD as well. So in the management, if they're larger than 1 centimeter, they should be resected. Most important thing is just not look at the polyp, look at the surrounding mucosa. Make sure you're not dealing with atrophic gastritis or intestinal metaplasia, because those are the harbinger conditions which are leading to these polyps. And so always investigate the surrounding mucosa. And again, check the H. pylori status. And if you find H. pylori, treat it, and then confirm that you have eradicated H. pylori in these people. Always biopsy extensively. The recommendation is follow the Sydney protocol, which is 2 biopsies from the antrum, 2 biopsies from the body, from the greater curvature and lesser curvature, and from the incisura, and send them in 2 different bottles, the antral biopsy and the gastric biopsies, to see if there's atrophic gastritis and the extent of atrophic gastritis that you're dealing with. So at least 5 biopsies. Some recommend 7 biopsies, but at least 5 biopsies should be done when you see hyperplastic polyps and you're looking for atrophic gastritis. So moving to the next one is the gastric net, which used to be called the carcinoids, but the classification has changed, and now they're called neuroendocrine tumors. And they're usually of 3 different types, and their difference is depending on the gastrin level and the presence of atrophy. So if the type 1 is with atrophic gastritis, they're usually multiple and located in the fundus and body with a low malignant potential. But they should be resected because of being nets. But endoscopically, you can manage these. The second one is type 2, associated with Zollinger-Ellison syndrome. They're usually, again, multiple, and they should be resected. The interesting story, I had a patient just last week who I had followed for about 10-15 years, presented initially for funded gland polyps. I had resected funded gland polyps, and then she was being followed by her primary GI doctor. And after about 6-7 years, she comes back to me, and this GI calls me and says, I biopsied this. I thought these were fundic polyps, and they came back as neuroendocrine tumors. I check a serum gastrin level, and it's 3,500. So this patient has been asymptomatic all these years, but has Zollinger-Ellison syndrome. So keep that in mind when you're looking at these things, and they can be mixed in with funded gland polyps as well, just FYI. The third one, which is the most difficult one to manage, are these solitary gastric nets. They are neither associated with high gastrin level nor with gastric atrophy. And that's what makes them more suspicious. They have a very high malignant potential. As I said, they have normal gastrin levels and no atrophy. And when you can resect them, smaller ones, endoscopically, but always think about these are the ones which are the ugly players, and they will show up 4 years later with liver mets as well. So these are the ones you need to be watching very carefully, do a complete resection, and get your surgical colleagues involved. Get MRIs, octreotide scans, whatever. But these need to be worked up more carefully rather than just resect and forget. Hamartomas are also part of the gastric polyp syndromes, usually found in children, usually with Peutz-Jeghers or juvenile polyposis syndromes. In the stomach, they typically don't cause any symptoms, but jejunal polyps can cause intussusceptions. And we had a really nice case demonstration yesterday of a jejunal polyp resection in our advanced endoscopy course. So just to keep in mind, they can be also in the stomach, and often you have to do a biopsy or resect them, especially if they're large. There's another mimic, which you can see often presents as a polyp with a smooth, shiny top. These are submucosal lesions which just show up and can often present as a GI bleed or peptic ulcer disease or iron deficiency due to ulceration. So keep that in mind. They can only be made a diagnosis typically with an EUS. And on EUS, you can see them often coming off the musculus propria layer. And their malignant potential depends on their size. The more than 2 centimeters in size, high mitotic index, or presence of c-KIT are the bad players. And these ones should have to be considered either, in some cases, endoscopically resected, but in most cases, they require surgical management. Other thing which to keep in mind for the endosonographers in the room is the doubling time on these things. So if you have a doubling time of 18 months, meaning a 1 centimeter comes back, it's 2 centimeters, these are the bad players. They need to be resected, cannot be followed, because they will end up causing problems in the future. Moving to gastric adenomas, again, the classification and the name has changed. They're now called raised intraepithelial neoplasms rather than adenomas. They can be of different sizes and forms. They come from multiple different cells within it. The intestinal foveolar ones are the ones which have a high malignancy potential. They have this velvety, rubbery appearance on the top. They can appear to have this little tubular villus appearance. They're usually large, and the larger they are, the higher the risk of malignancy. And up to 30% of them may have synchronous adenocarcinoma. So watch carefully. A very good endoscopy to look for the rest of the mucosa, looking for malignancy is important in these. And again, these are also associated with possibly a background mucosal atrophy. And again, H. pylori is very important to make sure that H. pylori status is known, and if known, treat, eradicate. Moving to the more uglier players is the early gastric cancers. I put this here because they come in all shapes and forms. They can come as ulcerated lesions. They can come as raised lesions. They can come as laterally spreading within the antrum. And the antral gastric cancers are obviously associated with H. pylori and have to be known. So they come in different shapes and forms, and in order to know what to do with these, you really need to know your Paris classification, because that Paris classification is going to determine how you're going to manage these people. Biopsy was the first. When you see these, just biopsy them, but then decide what you're going to do with them, because the literature from the Japanese shows us that if you resect them and they're appropriate candidates for resection, 5-year survival for an early gastric cancer managed endoscopically is 95%. So they can be managed endoscopically. They often do need an EUS to kind of see how deep they go, to look at the lymphadenopathic pattern. But the type 1s and some of the 2s can be managed endoscopically. When you get into the 3s and 2C, 3s, these are surgically managed. But here the important thing is to determine how to manage them. Polypectomy is probably not the best option. Because you will leave something behind, and that's the last thing you want to do, is do an incomplete resection, and then the patient comes back with advanced cancer because of lymph node. You never cleared the margins on this thing. So EMR and ESD are the recommended endoscopic treatments for this. Before we move forward on how to manage and what I would do in these patients, I want to spend a few words on gastric intestinal metaplasia, which again, follows the same sequence as adenomas in the colon. They follow this chorea cascade with a normal mucosa, which turns into a non-atrophic gastritis, which then becomes multifocal atrophic gastritis, and then you start seeing intestinal metaplasia, and then complete intestinal metaplasia. Under certain genetic conditions, it becomes incomplete, and then you're down this cascade of adenocarcinoma. So it's important to know this and keep this in mind, because this is one cancer, one thing that you can prevent from happening if you are following this. Again, very important to know for the atrophic gastritis, intestinal metaplasia, multiple biopsies, 2 separate containers, and spend your time. These are not 1-minute or 2-minute endoscopies, which are typically seen. You have to spend your time looking at the mucosa, carefully studying the antrum, prepylorus, proximal antrum, lesser curvature. And there's a very good studies on how you can recognize intestinal metaplasia just on endoscopic evaluation. You don't have to do a biopsy, confirm it with biopsy, but you can find intestinal metaplasia just on a good white light endoscopy. You can see this irregular mucosal pattern, tubular villus pattern, and it's up to 89 to 90% specific that there's intestinal metaplasia. And this, you can biopsy, targeted biopsy, because intestinal metaplasia cannot be all over. It can be focal, and it's mostly focal. So you have to target your biopsies at these lesions and then kind of confirm that. A very good examination is very important, and I can't stress enough on how much you should work on it. And I think if you just dwell on this little thing, that you can miss GIM and early gastric cancers up to 25% of the patients. And the biggest thing they found is inadequate examination. And what is an inadequate examination is when you don't clear up all the mucosa, you don't spend time looking at the mucosa very carefully. And here's 2 examples of a good examination and a inadequate examination. Here, they've cleared up all the mucosa, all the bubbles from the mucosa, spend their time looking at the fundus carefully, looking at the lesser and greater curve antrum prepyloric area. So spend your time, and the recommendation is to spend about 7 minutes looking in the stomach. Sounds like a long time. It feels like a colonoscopy, but important thing that if you are considering GIM, you have to spend time looking at the mucosa. White light is as good as finding with image enhanced light, but if you keep that in mind, if you have an image enhancing modality on your scopes, always use it in these people. And yet you can see here on mucosal patterns, this pattern, the first picture, looks different from here. You can pick up this loss of folds, this prominence of the submucosal venules, and atrophic mucosa, which becomes more prominent on your MBIs. And here, again, intestinal metaplasia, you can see this villus pattern around these whitish streaks. And obviously, if you start seeing raised lesions or early adenocarcinomas, you obviously start worrying about it. I'm almost out of time, but I hope I can be yielded the time that my earlier speakers went early. So endoscopic examination, you can make a diagnosis of polyps and metaplasia on a good examination, but it's important to see where these polyps are. Fundic polyps versus antrum, you can clarify your differential diagnosis significantly. Gastric fundic polyps, as I said, are fundic. Antral, usually hyperplastic polyps. They look different. Mucosa or submucosal, we talked about that. Size is important in how you manage them. The larger they are, they should be resected. The smaller one, gastric fundic polyps especially, can be biopsied and forgotten about it. Look at the surrounding mucosa. We talked about that. Mucosa around there with surrounding atrophy, high risk for progression of disease. Look for adenocarcinoma. Look for early gastric cancers. And obviously a good history. Look for H. pylori, how much PPIs they use, history of syndromal causes, and a family history. What do I do with them? Again, we talked about you can just biopsy them first, confirm what you're dealing with here, and then make a plan on what you're going to do next. EUS may be helpful, especially if these submucosal lesions are appearing or the early gastric cancers. Endoscopic treatment is either an EMR or an ESD. Then in your ugly cancers, have your surgical consult available for you so that they can help you if they are you're dealing with something more uglier. More important thing, I want to make sure, be prepared to deal with these consequences of resection, because these lesions bleed. They are ugly, they can bleed, so make sure when you come out of these, you have good vascular control when you've resected these lesions, because otherwise your colleagues are going to be angry at you 2 days later when they show up in the ER with the melena, and not they'll have to take care of the bleeding for you, and that's happened to me. Follow up again. Once you decide on follow up, you have to have a plan on when you're going to follow them up. Just a few words about EMR and ESD techniques. We'll not spend much time, but once you have found dysplasia, you have to have a protocol in following them. So if you have a low-grade dysplasia with a visible lesion, resect them. And if you have R0 resection with these dysplastic lesions, you can follow them once a year. But if you are not seeing a visible lesion, you have to be followed every 6 to 12 months for progression of visible lesions. If you have high-grade dysplasia, if you have a visible lesion, again, resect them, but continue to follow them more carefully. But if you don't see a lesion and there's high-grade dysplasia on biopsy, they need to be followed every 3 months with systemic biopsy according to Sydney protocol in order to continue to pick up early lesions. So I'll stop here. Thank you very much. Oh, just one more slide, I guess. And the non-endoscopic management. Again, we talked about H. pylori, confirm eradication, look for autoimmune gastritis, and then the role of PPI as we already talked about. So thank you very much.
Thank you, sir. The next speaker really does not need any introduction. I invite Professor Lubna Kamani, who is the professor and director of GI residency program at Aga Khan University Hospital, Karachi, to tell us about facts and challenges of colorectal cancer screening in Pakistan. Welcome, ma'am.
Thank you very much. I would like to pay my gratitude to the organizing committee, Professor Sher Rahman, Dr. Kamran, for inviting me. Peshawar holds a very special place in my heart. This is the podium, this is the place I started my Woman in GI journey. So thank you, Peshawar, once again for inviting me. And it was 2019 that I presented this, the same place. But it was not Serena, it was PC at that time. So my topic is colorectal cancer screening. I guess it's very difficult after hearing all the, elegant talks in this session. And I'm not sure whether Helicobacter can cause colorectal cancer or not. But definitely we have gastric polyps, we have colorectal polyps as well. So that is the connection, yeah. So what are the challenges we face while screening for colorectal cancer? So what is screening basically? Let's start with a simple definition, especially for the residents and the students sitting here. A public health service in which members of a defined population, now this is very important word, are examined to identify those individuals who would benefit from treatment. So what is the benefit? Of course, to reduce the risk of the disease or its complication. And in this case, it's cancer. So this was a study which was done by a very own Professor Asma Shaukat, and mind you that she has done some remarkable work in gastro and in colorectal cancer screening and colon cancer. And according to a study, basically the screening reduced all-cause mortality by 2%. So this was the guideline in 2021 by ACG, and what they have recommended to get screening between ages 50 and 75 years, but at the same time they have suggested to do screening at the age above 45 for certain reasons. Because if you see that colorectal cancer incidence over time in the US has increased, and more colorectal cancer cases are evident at a younger age group, in 30s and even in 20s. We don't have a national data. We don't have a colorectal cancer registry in Pakistan. So we don't know exact numbers what we have in Pakistan. So that's why I'm sharing the international data. So if you look at the colorectal incidence, basically, the above one shows aged between 20 to 50, less than 50 years. You see both men and women. There's increased incidence of colorectal cancer over the years. Whereas in the age of 50 plus, the incidence is decreasing because we start screening 50 plus. So in the younger age group, it's increasing. That's why the age for which colorectal screening should start shifted from 50 to 45. And soon it will become, I guess, 40 plus. So it is a myth that this disease just affects men. It affects men and women almost equally. And you can see over the time, incidence among men and women, and also the mortality among men and women increases. So what are the barriers and challenges? So there are general factors basically. One is awareness, one is cost, of course, being a developing country. There's no national screening program. Patient has to pay from their own pocket. Then there's gender specific. Of course, I'm standing here, so there has to be a word gender in my presentation. Male and female. Then there is patient specific, fear of the procedure, embarrassment, accessibility, people living in far-flung areas and less developed areas. They don't have colonoscopy facility available there. And especially for the female, especially if they don't have any chaperone, male colleague, they cannot come in a facility in bigger cities. So this is the problem. Then we have GI physician. We have our own limitations. This is also a challenge. The ergonomics, we can't do unlimited colonoscopy in one day. Burnout is an issue. And of course, the availability of proper equipment. And of course, if there is any polyp in that, the polypectomy. And then there is combination of factors in most of the cases. So this is the slide I borrowed from ACG. And these are the disparities and stratifications at an international level. And if you see that most of these barriers will apply in developing country as well. They are also talking about cost, insurance coverage, education level, occupation, sex, socioeconomic factors, basically, income and language issues. So coming to South Asia first. So what are the barriers to screening? Unaware that colorectal cancer screening was a problem in their communities. considered colorectal cancer screening as a low priority. When I was in a medical school, I was told that colon cancer is a Western disease. We rarely see colorectal cancer in Pakistan. Women often thought that colorectal cancer is often a male affecting disease, basically. Then the physician influence on screening decision is high. Whenever there is bleeding per rectum, the general practitioner, GP or internist always thinks that it's due to hemorrhoids, and the patient is not actually referred to gastroenterologist for colonoscopy, and it's being treated for a couple of years for hemorrhoids. Sentiments of shame and modesty may prevent screening, especially in Muslim countries. So these are the barriers. Some people prefer the same gender endoscopist. Even men prefers men to do colonoscopy, and sometimes women also prefers women. Embarrassment, cultural issues, stigma, taboo. Reluctant for colonoscopy preparation. Sometimes when we ask patient to do prep, they are afraid and they just ran off that I can't bring that, ugly solution. Cost and lack of insurance cover. Fear of procedure and its outcome. What happens if something comes out? I don't have any symptoms, so I don't want to get it done. Availability and access to health facility, rural versus urban living. So what challenges we have in Pakistan? Further narrowing it down. The alarming surge of colorectal cancer among younger population. We don't have a nationwide study, but we do have certain selected studies, which I have mentioned in the lower down panel, that there is the colorectal cancer are now being seen in the age of 30s and even 20s. Lack of awareness by the patients as well as the physicians. Then they are challenged. Obesity and sedentary lifestyle leads to increased cancer. Absence of national screening program. There is no available data. Scope of program, scope of disease is not known. Dearth of local literature and research. Genetic predisposition. In Pakistan, we see a lot of cousin marriages. So this is one of the causes that might lead to, a genetic predisposition for the cancer. Social determinants of health. Cost, insurance coverage. Cultural, social barriers, stigmas. Non-availability of facility or preferred gender endoscopist. So in Pakistan, I did a study, a nationwide study. We have completed it. It is in the process of publication. And we took patients from all 4 provinces, and it was study done over 5,000 patients, basically. And the main barrier was lack of awareness. Patient did not have any knowledge. More than 2/3 of the patients said they don't know anything about colorectal cancer screening and how to do it and whom to approach and when to approach, basically. And the second was the cost, and the third was the preferred gender endoscopist availability if they want to do it. So these are the financial limitations. If you can see, unfortunately, what is the expenditure on health per capita? In Pakistan, it's just $69. So this is the problem. If you don't, there's a basically common perception in Pakistan, if you don't have any problem, why to go to a doctor? Why to go for screening? Or doctor kuch na kuch nikal hi lega aur phir chakkar mein padenge. So this is the common line that they say, that we don't have any problem. No, we don't want to get it done. So this is again a slide which I borrowed from ACG. It's a equitable health availability, and it's availability for the whole person in their lived environment, basically. The right care, the right population, the right time, in the right setting. And it has to be accessible in the area where they live and work. So these is common. What they are talking about is education, socioeconomic factors, family support, income, and it is the main determinant, 40%. Then there is 10% the physical environment, then the 30% is the health barrier, basically, behavior, and then is the 20% is the accessibility and healthcare. So this was a study that they have done. And what they have seen is in outreach with colonoscopy versus FIT versus usual care. So if you do an outreach colonoscopy service, there was improvement. But if you go for non-invasive the compliance was even better, and the program was even better, and more people you can engage for the colorectal cancer. So non-invasive testing is one way if the patient has fear. uh, Again, the sensitivity and specificity and how do you do it, that calls for another lecture. The non-invasive testing, this was another interesting study which showed identifying gender barriers for colorectal cancer screening and assessing the need for a multi-gender endoscopy team. And they have seen that patients usually prefer for the same gender endoscopist. They are willing to wait, they are willing to pay more. And this is an Western data. So you can imagine in a Muslim country like ours, what will happen, that female wants a female endoscopist. So keeping this in mind, me and my colleague, Dr. Nazish Bhatt, did a study on unique perspective of Muslim patients on gender preference for GI endoscopists. But because whenever I say to my colleagues that female prefer female, they said, no, we are doing female all the time. It's nothing like that in medicine. So I thought that why not to do a study and prove. So why this study is important? Patient perspective, 22 to 70% of the women prefer gender preference basically. And if you can see, that the male also preferred male gender endoscopist and female also preferred female endoscopist. And this was the study, which was multi-center study done over 1,000 patients basically. And they were willing to wait for more than 7 days to get their preferred gender endoscopist. So recruiting diversity in providers can recruit more patients to their own healthcare. So keeping this in mind, I started the first woman-only endoscopy service in Pakistan at Liaquat National Hospital, where all the staff and the doctor will be female. So what are the challenges for female endoscopists basically? There is altered female endoscopist to female patient ratio, which will turn to too much work, exhaustion, burnout, altered work-life balance. Ergonomics, this is for both basically, the male and the female. Does gender matter? Basically, in ergonomics, there's if you don't take mini breaks, female are more prone to cervical and hand injuries, whereas men are more prone to lower back and knee pains. Unable to complete difficult colonoscopy. Female are more, obese. They have hysterectomies. They have pelvic surgeries. They have long colons. The colon is more redundant, there is more looping, and they have low pain threshold. So we have to keep that in mind. Difficulties in GI training of more, and a female endoscopist, and not just doing colonoscopy, doing more advanced procedures like resecting larger polyps and EMD and ESD is a big challenge in Pakistan and globally. So this was the study we did, write up challenges during colonoscopy and how to do colonoscopy, especially in patients with prior hysterectomy, and we have given some tips that how to do it. So this is the burnout of the GI physician basically, and you can see that the gastroenterology is among the top, 12 specialty in which there is burnout. But there is light at the end of the tunnel. So there is rising trend of women in gastroenterology. Although the data is a bit old, it's a CPSP data, and you can see that the supervisors, there were only 4 female, but when you see the trainees, there are 40% are female trainees basically, and now few of them are already consultant. So yes, there is growing number of female gastroenterologists. So hopefully in every city, even in rural areas, we will be having a female endoscopist, and this will not be a problem in future. Talking about little bit of ergonomics, and this is for us basically. There has to be a proper, working station, because it's not a one-day job. You have to live with this. You have to do endoscopies almost daily and in numbers basically, especially those who are working in tertiary care hospital or in multiple hospitals. So the monitor should be at height. So it has to be adjustable. Your position should be in neutral positions, the arms. Need to have a gel foam or the soft cushion sole shoes basically, and the patient's bed should be at the elbow level to avoid extension, flexion and bending. So I did a study on ergonomics, injury, and endoscopists and their relative risk factors, and it was compared with a non-endoscopist basically. And if you see that there were 95% of the endoscopists had some sort of injuries, and the most important, no, most prevalent injury was back pain. 40% had back pain, followed by leg pain, hand pain, and wrist pain. Because one size does not fit all, the scope manufacturer make the scope of one size, but because there's a huge variation among the build from Asia to US basically, and female are at disadvantage because of their grip strength are less, so they have to apply more force basically to provide the same force. Then the anxiety and pain during procedure. One is the main factor, and most of the patient either they ask us to do it in general anesthesia because they don't want to get it done in sedation, or they ask for more sedation. So we did this musical study. We in the intervention group, it was a natural soft music were given to the earphones, and we saw that there were less pain, and there was the procedure duration was less, and there was in the intervention group, and the anxiety score was also less in this patient. So the take home points: screening for colorectal cancer is effective and saves lives in both genders. Need to develop a model for developing country like Pakistan. Stratify barriers and facilitators to colorectal cancer screening. Physician and public education, both. We need to educate the patients as well as the physicians, the general practitioners, that whenever there is any alarm symptoms, please send it to a gastroenterologist. Equitable access to both genders, urban and rural areas, and rich and poor. Epidemiological studies, robust national cancer registry. Non-invasive colorectal cancer screening tests in future will mitigate these barriers to some extent. We don't have fit widely available or Cologuard, so we rely on stool for occult blood, which is not very specific basically. Training of more endoscopists, especially females. Strong need for ergonomic focus specific training for endoscopists, and this is for our own health and longevity. Availability of less expensive and more culturally acceptable screening tests. Cost-effective analysis. Engagement of community health workers. And last but not the least, political will and government priority. Just like there is a priority for breast cancer, and if you see in October, there's Pink October, and all the medias and the parliament is lit up with pink lights. We need to gear up that March is a colorectal cancer, so it has to be blue. It has to be seen everywhere that yes, it's blue. So we need to be more proactive as a gastroenterologist, so that we are the stakeholders. We need to give government the direction that yes, we need to have national screening program. This was the Blue Day that we observed in 2022 and was tweeted by ACG. Thank you very much, and thank you once again for giving me this opportunity.
Thank you, Dr. Lubna. It was a very nice talk. Now we have come to the end of the session. How many of us want to have an early tea, or how many of us want to have a discussion on the talks? Everybody is saying we want to have discussion on the talks. So house is open for the discussion, but quick questions. The tea will be served at 4:50, so we got about 6 minutes. So starting with the first talk, endoscopic management of obesity. Do we have any question, sir?
So again, Hamad, many congratulations. How do you select your patients? And precisely what I want to find out is, do you look at these stages of fibrosis with regards to the patients who have underlying liver disease, please?
Thanks very much. Great question. How do I select patients? The first answer to this, there is no upper limit to BMI, and there is no real contraindication to do the procedure. Anybody who is overweight and obese can have the endoscopic bariatric treatments. Some relative contraindication, I'm sure I don't need to go into the details of. And I do not particularly do specifically the liver-related patients, but any comorbidity is, known in association with obesity obviously adds more value to select the patient for the endoscopic procedures. It usually is more to do with the patient choice, to be honest, than anything else that triggers.
So I think it's more of a personal perception. Anybody who wants to lose weight, starting with BMI of 25 or 27 onwards, ji Saad bhai.
Just wanted to know, when you're counseling your patients, how do you advise them to have, you said you have no limits for BMI. How do you decide which patient should go for surgery or would have better results with surgery versus what you're doing, especially in patients with higher BMI, number one. Number two, what is the cost difference percentage-wise between surgical and endoscopy?
Thanks very much. I'll try and answer the first question first. Sorry, I totally lost the first part of the question. Can anybody on the desk remind me? Because now I'm focused on how to answer the cost question.
The counseling that you do in terms of outcomes, and number two, the cost difference in the bariatric.
So anybody in class 3 obesity and beyond, I try and encourage them and send them to the bariatric surgeon. I work.
That's what my point was. You said that there is no limit.
There is no limit. That's the patient's choice, and but I send all of the patients to surgeon because I work alongside them. And then they have a discussion, and then they choose. And secondly, the cost difference is huge. Surgery is well established, and very, very cheaper tools are available. And many a times it is available in the public sector, as part of training, etc. Whereas the newer technique is significantly expensive as compared to surgery. So I do not think I can give you a clear answer what the difference is. But in the same hospital, if my patient wants to have a surgical sleeve and would rather choose the endoscopic sleeve, they will pay 3 times more.
The surgical sleeve with a minimum cost of consumable is 3,75,000. And the minimum cost of endoscopic sleeve gastrectomy is 8,50,000. So definitely, in terms of strict consumable,
absolutely.
So 3,50,000 against 8 lakh.
Roughly 3 times is my estimate.
Any BMI above 35, it is best to refer the patient in terms of counseling for the surgical and not for the endoscopic. Yes, we can downstage the people with intragastric balloon when the people are too obese, maybe BMI above 45 or so. Yes, sir.
Wonderful presentation by all the speakers.
थोड़ा सा ऊंचा बोल ले माइक के अंदर yeah.
Wonderful presentation by all the speakers. My question is that what is the effect of these stomach size reducing procedure on the secretions of the stomach, like enzymes, hormones, and acid secretion?
So, thank you, sir. I don't think there is any significant difference in the acid secretion. Talking about the reflux disease, I could comment that the surgical sleeve would increase the risk of reflux, whereas the endoscopic sleeve would reduce or actually treat it.
Is there any study?
Yeah, it is proven. And the gastric hormones have also been studied. The ghrelin hormone, particularly the hunger hormone, that has a particular pattern, it reduces and then increases at a later stage.
So thank you, Amat.
Thank
we
you.
go to the next talk. Bariatric surgery complications. Any question? Ji, Jindeep bhai.
Quick one. I think I was inspired to see your endosponge, which I believe you have sort of come up locally. Because I think, again, the cost, that's going to save you a huge cost. The one we have available cost us around £2,700. And I guess the one you are making with the catheter, so that is phenomenal. I guess, I mean, if there's a possibility of you doing a trial side by side, that
ये वही surgical endosponge है जिसको catheter के साथ attach करके तो हम push करते हैं. So can we have a mic for Dr. Agyas? Mic कहाँ पे भाई? ओ भैया mic दो यार.
So endoscopy vacuum therapy is a very simple technique. We can use sponge readily available from any surgical store, or alternatively we can use this gauze piece, and we wrap it around the distal end of our routine nasogastric tube, and we attach the suction with that. And the basically the technique is a little different. We pass the NG through the nose, we take it out from the mouth, we attach the gauze or sponge, we wrap the suture around it, and we cover the basically the whole all the holes at the distal end of NG, and we take it down to the desired place with the help of our forceps. No, we apply the suction, and the rate of suction is roughly 125 pressure, and we can do the continuous suction if the patient tolerates, or we can do the intermittent suction depending upon the patient tolerance, and we need to replace it every 3 to 5 days.
Okay, so next talk, non-varicose upper GI bleeding management strategies. Any question? None. So next is Helicobacter pylori management east and west. Well, Dr. Shfaq, the study that you quoted, you see Helicobacter pylori is a different ball game in Pakistan. Everybody's Helicobacter pylori positive. Let me tell you, the people who are sitting in this hall, 90% will be positive with Helicobacter pylori. So for us, Helicobacter pylori is a different beast. And the management, the study that you quoted, 294 patients coming from Sargodha, Javeria presented that study. Sample size is too small. Giving a recommendation based on that study while so many other good studies are available, I think that will not be fair. Moxifloxacin, fluoroquinolone resistance rate is above 50% in Pakistan. Amoxicillin above 38%. Nitramidazole above 65%. What else? Clarithromycin above 60%. So anything less than CBS based, quadruple therapy, sequential therapy, and minimum 14 days therapy, that doesn't work. And we have the guidelines as well available on that. So I think Helicobacter pylori, little different message could have been given to the people. So I understand that you're working in UK, so the local scenario probably you have not been able to grab that. Yes.
So, question for Dr. Ishfaq. So just can you guys hear me? So the studies have shown that vonoprazan has actually better efficacy against H. pylori than PPIs.
Yeah.
So is that something that we can incorporate into our practice? Because I've been lately doing that. So I just wanted to get your opinion. What do you think about that?
I think vonoprazan based CVS, vonoprazan and quadruple, I think that's the way to go. Ji, Dr. Lubna?
What we see in our practice that the patient is repeatedly advised to do Helicobacter antibodies, and it's positive and positive, and they are taking courses 4 or 5 times, and this leads to antibiotic resistance. So at a PSG platform as a national society, can we recommend to government and the laboratories that stop doing this test, just like the infectious disease society have recommended to stop doing Vidal test for typhoid.
This test should also be withdrawn, because this is an epidemiological tool, not us.
We can write a recommendation letter to the authorities, because in the era of antibiotic resistance, this will make things more worse.
Agree. Yes, Ishfaq.
So I've got no experience. I think that the drug you mentioned is not available in the West anyway.
Okay, so next talk is...
One more question. What about the role of probiotics in Helicobacter pylori treatment? Addition of probiotics with antibiotics?
I think there are some anecdotal studies that it is helpful to relieve the symptoms, but not for eradication.
देखिए इशफाक भाई ने पहले कह दिया था कि मैं कॉलन का बंदा हूँ, मुझे हेलिकोबैक्टर पायलोरी ना पूछें, बस कर दें. So next topic है, क्योंकि कामरान ने कहा कि 450 पे चाहे.
Question, I have one comment regarding the recommendations from PSG regarding the stoppage of H. pylori screening test. I think it needs lots of debate, because we see gastric cancer quite common in our society, and H. pylori is one of the documented reason and causative organism for development of gastric cancer. I mean, based on...
logical, epidemiological tool.
No, sir. Like if somebody is having epigastric pain and we are not eradicating H. pylori, if we find H. pylori, we need to document whether this is active infection or it's just a seropositive type of thing. We should have recommendations which are very genuine. And because we have a very strong causative relationship of the H. pylori with gastric cancer. So I think straight away removing it from the paradigm, I think it's not wise right at this moment.
I think we need to have a separate session on this particular issue. So next is updates on functional dyspepsia and its management. Any question? So Professor Javed Farooqi highlighted heavily on icosiamide, but there are lots of patients who don't benefit from anything that we give. So virtually gastroparesis, especially the diabetic patients, people who got young patients with idiopathic gastroparesis, the surgical management, endoscopic management, they need to be considered in these cases. Gastric polyps, how to proceed? Any question? And finally, yes, Bilal.
So I have a question. If you have a type 2 gastric GNET, would you recommend all those patients, I'm specifically asking about type 2, for dotatate scan, gallium dotatate scan? Is that something you routinely do?
Not for type 2. For type 3, yes. The other thing is, for these people I didn't mention, is they often benefit from entrectomies. Surgically, they benefit too. If they come again and again with neuroendocrine tumors, especially type 1 and 2, the driver is the gastrin, which is you can eradicate with entrectomies. So I've seen in my own practice that when we've done entrectomies, these tumors vanish, and I've followed them for 4 or 5 years and have not had any recurrence after that.
Okay, thank you. And colorectal cancer screening, facts and challenges? Topic.
I think that's my pet topic. Thank you very much. Very impressive talk. My question is, 4 or 5 years ago, I raised the idea of a nurse endoscopist in PSG forum. That was a WhatsApp forum. I was slammed so much, I left the forum since then. Never joined back.
Slamming की बात नहीं है, बात है कि अभी we are not there yet.
Yeah.
Nurse assisted the colonoscopy or nurse administered colonoscopy. These are two different things.
Yeah.
So nurse assisted colonoscopy, we do all the time. But nurse administered colonoscopy, I think we are not there yet because our nurses are not trained to that level at the moment.
Going back to the gender, that we need more female gastroenterologists or female endoscopists. 30 to 40% of our colonoscopies are done by the nurses, who are the females, and they're easily available. Wouldn't that be a good idea to have gender presence for female Muslim patients?
ये इसी माइक पे आ जाए आप. डॉक्टर लोकना, मेरा भी एक सवाल है कि वो तो था आपका सर्विलेंस स्क्रीनिंग पे, आपने इकोनॉमिक्स पे सब कुछ हमें
स्क्रीनिंग बैरियर्स है. अब मसला ये है कि whenever the term, I come to Dr. Ashwaq question later on, first I'm answering his comment. Barriers and challenges में there is patient, there is doctor as well, and there is circumstances. We always talk about patient, forgetting our own well-being. Well-being comes first. And people sitting here have experienced back pain, wrist pain, the burnout. It's real. I don't know why we don't take care of ourselves. We have to take care of ourselves. Then only we can take care of our families and our patients. So this is very important. This is one of the barriers of colorectal cancer screening, that if there is 50% patients female, so we don't have 50% female endoscopists. And Nazish is sitting here, would agree that we are overburdened basically. But this problem will solve with non-invasive testing like FIT. And this is what international literature is also saying, that FIT and Cologuard test. And those who are positive then can be sent for the, colonoscopy. So this will reduce the numbers in future. One of the companies have bought FIT, but it's very, very expensive. So probably we need to have more generalized availability of non-invasive tests.
I just wanted to make one more comment on that. I agree with Lubna. I don't think we should be pushing for nurse endoscopists. Even in the US, there's been a push for doing nurse practitioners. It's not very well received. And it's just not doing a colonoscopy. Doing a bad colonoscopy is worse than doing a colonoscopy at all. I mean, missing a cancer in a patient who had a colonoscopy 1 year is the worst news you can give the patient. And so quality of endoscopy is very important. Just like you're talking about these adenoma detection rates all the time, I think I can just imagine we are fighting good quality endoscopy in Pakistan right now. Gastroenterologists trained are not getting enough endoscopies here. And we're talking about nurses. I don't think that's a good idea to fly. At least it's never going to fly.
And number two, because if nurse is doing a colonoscopy, she won't be able to remove polyps. Then the patient has to refer for another endoscopy. So in Pakistan, patient won't be able to, pay twice or thrice. So that would be another problem. And if the nurse is doing a therapeutic colonoscopy, then there's another debate.
So no. I think that leads us to another study. We can take you can do another study asking the females if they would prefer having their endoscopy done by nurses versus male doctors. Maybe they are available.
It's already
we can
proven.
continue this discussion.
No. It's already proven. Nurse endoscopists, I would preferably have my colonoscopy if needed by nurse endoscopists. I have got no objection. I know that she's trained. I know that she's competent. I know that she can remove some type 2 polyps, so level 2 polyps. So I think this is a myth that the nurse cannot do. And the nurses I have seen or trained in the past actually trained 30% or 40% of gastroenterologists in UK. And the gastroenterologists who are trained by the nurses, they prefer to go to the nurses list rather than the consultant list.
Dr. Shwak, one more point. Over there, the patient is not paying from the pocket. Here, most of the patients are paying from their own pockets. So they don't even allow the resident or the fellow to start the procedure. Sometimes the demand is the consultant will do it. Yeah. So here, there's no government program, basically. There are very few centers, government, that does free colonoscopy. Even in some government hospital, they charge a minimal fee. So in private, basically, in NHS, they don't have time. They wait for 6 months to get a colonoscopy.
I think we can continue the discussion over tea now, okay? He had a good nap, so he's fresh. We all need a cup of tea to be fresh. Thank you.
Thank you
all
so
the
much.
speakers.
This concludes the session. Thank you to everyone.